Welcome to This is Social Work. I'm Matthew, Social Work England's Regional Engagement Lead for the North West of England. In this series we're focusing on the professional standards, the 6 standards that social workers must know, understand and be able to do as part of their role. The professional standards are specialist to the social work profession and apply to social workers in all roles and settings across England. In this episode we're focused on Standard 3, which is be accountable for the quality of my practice and the decisions I make. Today I'll be joined by George, who's a lead forensic social worker, and Calum, who is an adult safeguarding team manager. They share their own experiences of decision making, particularly in relation to safeguarding, and discuss how social workers identify risk indicators and cope with the demand that this places on their own well-being. We hope you enjoy the conversation. So we're going to make a start with some introductions. So George, can I come to you first and just ask you to introduce yourself and to give a bit of background as well about your social work career?
Okay, so my name's Georgina Adams. I've been qualified as a social worker since 1993, so it feels a very long time. And for all of my social work career, I've worked in Devon for Devon County Council. My background predominantly has been around children's social work. So the first kind of 25, 30 years of my career, I've worked in social work, whether as a social worker, as a team manager, chairing child protection meetings, or as an independent reviewing officer. I've also worked for a safeguarding board. I worked there for a few years and managed the child protection service in Devon for a few years as well. Well, as part of that career, actually, I'll go back a bit, really. I worked for the emergency duty team, and up there I was predominantly a children's social worker, but I also did my AMP training. So I did some work there, working as an AMP in mental health services. But I've taken quite a different career change very recently, in that I've become the lead social worker for the secure services here at Langdon Hospital in Devon. So we are a secure hospital with roughly about 110 patients, all male patients. And we have 4 wards that are medium secure wards, 2 wards which are low and 1 ward which is open. And I also have, as part of my role across the secure directorate, although I line manage 7 social workers here in the hospital, we have social workers that are also working in our community forensic team and our liaison and diversion team. And I take a responsibility not for line managing them, but providing some professional supervision when needed, and also making sure that their social work voice is heard across some of those agencies where they're working, particularly when they're in the police. And we're also making sure that their CPD is up to date and they're thinking about some of those social work issues. And they come to some of our forums and come to our training. So although I only kind of line manage 7 social workers in our hospital, I have a kind of broader role across the secure directorate here.
Perfect, thanks George. Calum, can I come to you?
So my name's Calum Titley. I work for Stockton Borough Council. So I qualified as a social worker back in 2009, and I've worked for Stockton Borough Council ever since. Prior to doing my social work degree, I just want to give you a bit of background about myself. So my kind of interest in working with people and, empowering people to kind of achieve and, contribute to society came from doing 2 years volunteering in America, where I was living and working with adults with learning disabilities. And it was that experience that really kind of demonstrated to me, just regarding kind of human worth and the fact that, we've all got strengths that we can contribute to society. So that really kind of shaped my career in, like I said, wanting to work within social care. And once that experience came to an end, I found myself applying to kind of study social work. Throughout my studying, I did statutory placements within children's services. So I did a placement within a child protection team. But my last placement was with adult services here in Stockton. And since that time, I was lucky enough to become employed as a social worker in an adult assessment team. Before then, developing through being able to do my practice educations awards, my best interest assessors award. I then transitioned into our safeguarding area. And since working in the adult safeguarding team, I've been the team manager of the adult safeguarding team here in Stockton for the last 7 years. I started as a team manager in the safeguarding team right when the Care Act was implemented. So straight away I had that responsibility along with kind of the other managers and senior management around embedding the changes into practice that came from the Care Act. I was actually successful in now being appointed as the dedicated safeguarding lead officer, which is going to be a little bit of a change in that I won't be directly responsible for managing the day-to-day operational practice here in Stockton, but I'll be more responsible for the work that is shaped by Adult Safeguarding Board and the assurance work that's required as part of being part of that board, as well as the embedding the learning from things like safeguarding adult reviews, etc. So my role is going to be slightly different moving forward, but still very much within the adult safeguarding area. What I would say is, I live here in Stockton. I'm proud to work for Stockton. They've invested in me, and I'm like I said, I'm proud to serve the people of this borough.
Yeah, and I mean similar to Calum, I only ever worked for one local authority. So before Social Work England, I only ever worked for Cumbria County Council and was really proud to work for Cumbria County Council. It's the area I grew up in, area where I still currently live. And it's only now that I stepped out to work for Social Work England that I've made that move away from an authority in an area that I'm really proud of. So certain similarities there. So today's focus is really professional standard 3, which is be accountable for the quality of my practice and the decisions I make. Now, professional standard 3 is the biggest. It's got 15 points. For me, professional standard 3 is a lot of the sort of day-to-day work that social workers do, because it talks about things like working within legal and ethical frameworks. It talks about evidence-based practice. It talks about assessments. It talks about working within multidisciplinary teams. It talks about record keeping. So that's the kind of, for me, for a lot of social workers that might be listening to this, is their day-to-day work. Standard 3 also talks a lot about risk, talks a lot about risk assessments and responding quickly to dangerous situations. So when we were thinking about Standard 3, we had to narrow down the 15 points, otherwise this podcast would be a day long. But that's why we sort of narrowed it down to that sort of safeguarding perspective, which is why we reached out to yourselves who've got that experience. Because I think, and we've already started to talk about it a little bit, social workers continue to take the lead in safeguarding in both adults and children's. I think the landscape's changed, and I think legislation's changed significantly over the last few years. Calum, I'm the same, thinking about what the Care Act's done for safeguarding in adults. I think that was a significant change for the whole system. But I think it's an incredibly demanding area of practice. It's a really challenging area of practice, but I think it's an incredibly important one. It's also potentially a really high-profile area of practice as well. And it fits into the idea that social workers' primary role is around public protection. And for us as a regulator, that is also our primary role. We have been established with a primary role around public protection. And we also want to raise the standards of social workers across England so that people receive the best possible support when they might need it. And that's our role and function as a regulator. And because ultimately, society's decided really that social work as a profession carries that significant risk, carries that significant importance, that it should be a regulated profession. Again, why Social Work England's in existence and why social work has been a regulated profession for a number of years now. And I think that helps sort of emphasise the importance of social work and the importance of the work that social workers do. But I think it shows that social workers on a daily basis have standards to meet and uphold, but they also have got to comply with legislation and policy and guidance. And there's a lot there for social workers to understand. And I think that's why your new role, Calum, around that, embedding some of that in systems and embedding that in practices, those types of roles are really important to support social workers. If we drill down a little bit more into the standard, 3.2 focuses around sort of using information from a range of appropriate sources, including supervision to inform assessments, to analyse risk, there's that word risk, and to make professional decisions and judgments. And I think just and I'll come to you first, George, around what's your experience really around doing that? Because I think on paper that sounds really difficult. How do you absorb all that information to inform decision making? And particularly over the last 12, 15 months that COVID has been here, and I think that's shifted how social workers have been able to do that.
I suppose the thing that really jumped out at me was what you were saying about the need to balance that public protection. You know, I work in a secure hospital with patients, and it's quite a niche role, isn't it? Working in a hospital, it's a very, very specialist role. Probably a lot of people don't really know what social workers do. You know, in a secure setting, really. Because, you know, essentially we are working with people. If you look at kind of, you know, our male prison populations, there is that preponderance, isn't there, of childhood trauma and mental illness. So the people in the hospital I work in, you know, the patients that are here, patients or service users, whichever, there's always a bit of a debate about which language to use, really, you know, are some of our most disadvantaged and oppressed and traumatized people that we're working with, you know, every day. But in the work here, what we're always thinking about, which is what forensic social workers do, is about balancing that public protection, because, you know, some of our patients here have committed very serious crime, but also thinking about their own rights as service users. And we're also constantly trying to kind of promote their quality of life, working in partnership with all the kind of professionals here. It's really key here. The multidisciplinary working is really, really key here as part of the work in terms of trying to help that kind of recovery model, because social workers here are that bridge back into the community, into, you know, living outside of the hospital, and it plays a key part of that. So we're there constantly assessing and managing risk. Every day it's about assessing, managing risk, whether it's about here in the hospital and how the hospital is managed and how patients are in the hospital, or whether it's about patients going out into the community and being discharged into the community when we're thinking about some of our Care Act responsibilities. Also thinking all the time about the legislation that we work with and about our policy that we work with. You know, it's very complicated trying to manage those legal frameworks and at the same time balancing, protecting the rights of different people, you know, whether it's our patients here, whether it's about the victims, whether it's about that public protection, and whether it's about our, you know, the family and friends that are you know, are still part of our patients' lives.
Calum, is there any points that you wanted to pick up there, or just sort of coming in around your experience around that assessment? I think, because it is quite complex, isn't it? And George has described a really complex picture there, but I think that's a reality. There's no getting away from the fact that there is complexity there. And just sort of your experience of that and how you've maybe navigated that.
Yeah, I almost feel as though social workers, they're in effect need to be a walking encyclopedia these days, the amount of knowledge that they need. You know, whilst I think, you know, social workers are very skilled in perhaps how they communicate with service users, you know, how they apply that person-centered approach, that strengths-based approach to their practice, about having conversations. It's all the other stuff around that they have to learn within the profession in order to meet the statutory duties that the legislations hold, the local guidance that might be applied. For example, in my area, safeguarding, all the guidance that's produced under our Safeguarding Adults Board, understanding the roles of partner agencies and what part they can play in the system. It can be a complete minefield at times. You know, the core message I try and deliver to my staff is about defensible decision making. As long as, you know, if your decisions are defensible, even if that decision ends up being the wrong decision, or, you know, as long as you're able to defend it at that point in time, that is a key message I always try and give to my staff. You know, we've got the 6 core principles that we work to as well. So we try and embed them into our practice as well, you know, and you know, some of them principles are second nature to the social workers, particularly empowerment. You know, we might be dealing with risk and working towards how we can keep that person safer, or how we can, you know, risk manage the situation that they're facing. But it's trying to ensure that we don't necessarily create dependencies and do the doing. It's, you know, it's very much about, I think, you know, good outcomes to me is where we've been able to empower someone to take control. Some of the other principles, particularly like the partnership arrangements, we can sometimes see many dilemmas in practice, particularly when you've got kind of like conflicting opinions between agencies. You know, there's certain agencies that might be more risk adverse than others. And it's how you kind of balance all that, but at the same time, still able to work together for the people that we're serving.
What it really is key for me here in this hospital is, that we are it's the stuff that you were just talking about, Calum, about but that being very person-centred, talking about that empowerment. Very much here, as you can imagine, in a hospital, we've got a very strong medical model here, and about being able to recognise about, what's strong about people rather than what's wrong with people, and really recognising that actually people, even though they're in a secure setting, that actually there's still a lot of good things there that can happen. I was just thinking about some things you were saying about how we have to know how much you have to juggle in terms of your knowledge, isn't it? And it's really clear that, isn't it, about when you think about the legislation, there are so many, aren't there, bits of legislation that we're always quite trying to juggle at the same time. And that's where supervision is so key, isn't it, about trying to really help with that, some of that reflective practice, isn't it, to think about some of the decisions that we're making, to think about some of those areas of risk, isn't it, and really using some of that evidence-based stuff that you were talking about, Calum, isn't it, to really think about those defensible decisions that we were making.
In all of this, we've got the policy, the guidance, the legislation, and all those things that we've all been describing, but at the centre has to be a person, and he's a person, isn't it? And I think whether that's a child or an adult, I think always remembering that, I think is so important for social work practice. And I think that's that relationship-based approach that I've always been really passionate about. It's essentially why I come into social work practice. And I think there's a danger, isn't there, that when there's all this going on, there's all this policy guidance, legislation, there's all this risk, there's all this pressure from other professionals, pressure from families, pressure from communities, pressure from society, all this going on, to forget that there's a person right in the middle, and that's the most important person to build a relationship with and build your decision-making around.
And that's why I think having come from a background in children's and coming into adult mental health, it's been really fantastic to look at the adult safeguarding and the changes that have been made in terms of the legislation around there, and that really about making safeguarding personal, isn't it? And actually having those conversations with people. And it's something I think that I think it's one of the things that social workers do very well, is bringing it back to the person, isn't it? And I think because children's work so differently, where the child is that focus and thinks about significant harm and what's in their best interest, and coming into adults where you're actually thinking about balanced rights and responsibilities, aren't you, needs and risks, and keeping it person-centred, isn't it, is a different approach to have. I think it's a constant battle here in the hospital to be kind of saying, but actually, what does the person want? What do they want from their safeguarding? Which for me is very different, I think, really.
It is, and I'm a strong advocate for the making safeguarding personal as that overarching principle of safeguarding practice, because I actually saw practice prior to the Care Act when it was under no secrets guidance, and it was very process driven, and I saw firsthand situations where the adult's voice become lost, and it was about safeguarding as opposed to working with and keeping that person at the center. And I think it's so important that we keep that person-centered aspect of our practice, where the person is at the middle, where we are working towards their desired outcomes, because sometimes, even if there are presenting risks, we, I think, need to be getting better at applying the positive risk taking to practice. And recognising that, under the Care Act, there's a duty to promote well-being, but there'll be occasions where someone's well-being potentially isn't impacted by what they're experiencing. And therefore, you've got that, at times, that ethical dilemma where you're balancing kind of rights under the Human Rights Act, for example. So that respecting what they're telling you and what they want to happen. I think the making safeguarding personal approach to that has enabled us to kind of do that more efficiently.
Did you feel a shift, Calum, when that was introduced? Because I was still in practice. I was working in Cumbria at the time where the Care Act was introduced, and I felt a shift. I felt the system maybe took a bit of a step back, but I think individual social workers maybe took a step back and thought, let's do things differently. Let's think about it in a different way.
Yeah, I would agree. I think there was almost an immediate shift. But with that being said, it has taken, I think, a number of years for us to be able to kind of evidence it well in practice. When I say evidence well, because we work under a statutory safeguarding board, we ultimately have to provide assurance into our kind of local safeguarding adults board, and that includes data. That includes audits, multi-agency audits, and over time, we've been able to, I think, develop our practice to be able to evidence that better. I believe that, it's always been happening, but we're much more equipped with being able to, I think, evidence it now in practice. So then when it comes to talking about your defensible decision makings, for example, the fact that we are able to evidence that better now means that I think we're better protected as a statutory agency, because as you alluded to, Matthew, it's the one area of practice when you kind of refer to safeguarding, that when something does go wrong, you've got that safeguard and adult review duty, as is the same with the kind of serious case reviews when you're kind of talking about children. It's the one area of practice that you are expected to potentially look at what went wrong and learn from that. So I always think that there is an underlying fear at times, but coming back to what I said, if you're able to put it all together, evidence the principles, work to the legislation, quote that you work into the legislation, then for me, it brings about that defensible decision in your practice.
For us here, although social workers take a lead in some of the safeguarding, it's very much, isn't it, everybody's responsibility. The challenge here is to bring everybody on board with that and recognising what abuse is, and I think we've come a really long way and made some real improvements about everybody kind of taking that on board and recognising that actually doing work around safeguarding is everyone's responsibility, but it's really necessary, and it's not just someone else's responsibility. It's for all of us, and just valuing the importance of it and not being scared of it, thinking, what happens now if I raise something as an issue, because it can end up, I think, in a kind of the environment that I'm in, just feeling like it's one profession's responsibility. So we've worked really hard to make it feel that we all recognise when there are safeguarding issues, and there is still, I think, a lot of challenges around that, because if there is a safeguarding issue between two patients and somebody maybe, for example, might be, something happens and somebody might have to change a ward because of it, we have to be mindful still of the other patients that are still around. You can't just move somebody and expect that the safeguarding issue has gone, because it will still be there, won't it, but may impact on other patients. But also recognising that the person that might be the alleged the alleged person that's done the abuse, that they still have their own care and support needs as well, isn't it? So you're constantly having to think about those things as well. It's not just a kind of linear process, is it? It's much more complicated than that.
It is. Like you said, safeguarding is everyone's business. We might hold that lead duty under the Care Act and Section 42 of the Care Act. We are the lead agency, but the way I apply that is, yes, we might take a coordinated approach, but again, coming back to the principles, one of the core principles is partnership working, and sometimes to make someone safer or achieve that person's desired outcome, we might have to link in and use legislation that falls under housing or falls under environmental health, or we might be heavily reliant on the powers that the police are able to apply. So, I totally agree with what you're saying there. I think sometimes as a social worker who might hold the lead duty, it can sometimes come across that they're the sole person responsible for it, and we need to be prepared to challenge, because actually that's not the case.
And I think we often rely on other agencies to identify and alert us to the risk. And I think it's challenging, isn't it? Identifying a risk or identifying a potential safeguarding is a challenge, isn't it? And I think there's a skill there in social workers working with those other agencies to understand the safeguarding process, to understand what risk means, to understand some of the potential warnings that may be there that need to be maybe investigated.
We've done some work around what the difference is between trading and exploitation, because it's, things can become, I think, normalised on a hospital ward, and so people need to be constantly aware of some of those things. That's why supervision is really good to kind of talk about, and some of the kind of reflective practice discussions that we have as teams, to kind of remind ourselves actually what is happening there. Is that actually about exploitation? Is there some grooming here? We're constantly having to have some of those discussions to remind us that actually this could be a safeguarding issue. So when you talk about somebody in safeguarding having capacity to understand the risk or harm, sometimes people may not, because they may not realise and recognise that they've been groomed by somebody, for example.
Yeah, and it's really complex, isn't it? And I think self-neglect's another area that's really complex. The Care Act brought that under that safeguarding umbrella. I'm keen to get your thoughts on that, because you'll have experienced a lot of that.
Yeah, and obviously, it's not that self-neglect didn't happen prior to the Care Act. It was just obviously, put into legislation as an abuse category. What I think that's brought about, Matthew, is a element of subjectiveness, because it's the one category that isn't done to by someone else. It's around that person and their behaviours and how they're living and at times choosing to kind of make potentially unwise decisions, for example. And what you find, particularly from a partner agency perspective, is you do get that degree of subjectiveness where things that to me as a social worker, where it's about well-being and strengths-based and person-centered, you get a lot of things labelled as self-neglect that for me as a social worker isn't self-neglect. And I think the approach we take here in Stockton aligns itself to the principle of proportionality. We always attempt a care management approach first, where we offer assessment, look to put services in for that person, because what we found is that there was things being referred in as self-neglect, where a partner agency was saying that there's all these risks, but then the actual person themselves was wanting support, and it was presenting itself as self-neglect because they just didn't have the right support in place.
That label then can kickstart some quite immediate action, can't it? Which in some circumstances isn't what that person wants. And I think sometimes taking that step back and having that more preventative approach is really key, isn't it?
And I think neglect is always a really tricky issue, isn't it? Whether we're in your and children's. But I just was interested, Calum, you saying about how subjective it can be, can't it?
Yeah. And, and cases where, self-neglect is present, and from a risk perspective, it's clearly been identified as something that we need to kind of, I don't want to say do something about, but, in terms of working with the person, at times there's the need to build a relationship over a long period of time before you're able to make any inroads in being able to support that person and change the kind of situation for the better. More often than not, it's not an area of practice that you're going to be able to address overnight. You can look to work in partnership to potentially reduce some of the risks immediately, but in order to make that ingrained change so that person's well-being is going to continue to be promoted into the future, that takes a long time to achieve.
That's interesting, isn't it? Because that goes back to what Matthew was saying right at the beginning about the relational work, isn't it, of social work, and about how important that is, isn't it? And you're right, isn't it? There is no quick fix. And sometimes I think there's some pressure from other agencies to have a quick fix, but actually those things do take time. And if we are going to follow some of those principles, from the capacity about empowering people, isn't it, and proportionality, and thinking about those, isn't it, working in partnership, that takes time. And that's where the skills of social workers are really key, aren't they, about the skills that they have in terms of kind of non-judgmental, isn't it, and having that empathy and that real genuine working relationships to build something, to bring about some change, isn't it, positive change that the person wants.
Definitely, how you referred to kind of social workers there, George, is exactly, I'd 100% support that, because they don't not necessarily seeing it as a problem. They'll still, for me, focus on strengths and, still come at it from a perspective of, trying to kind of empower that person to see them strengths and contribute to their society, etc.
Yeah, and that's where I think working here is a challenge, isn't it? Because we are working every day with patients that are in a secure setting and thinking about them being discharged in the community. And it is that real, as you said right at the very beginning, Matthew, balancing that public protection, isn't it? And also the rights of families and victims, and thinking about the map of the public protection and how you manage all of that, but still maintain holding on to those, the individual rights of that person and about what's best for them. Because what we hope here is that people can go back into society and make a contribution and go back to leading and, an ordinary life.
We often refer to putting services in place for people. Well, I'm a firm believer that a response from a social worker is a service in its own right, because of the values that are often upheld and what they want to do in terms of, like I said, empowerment and supporting the person to kind of make change and contribute to society. The amount of information that a social worker might be able to offload onto a person and signposting and linking them in with their communities, etc. For me, that is a service in its own right, and I don't think it's always seen like that.
And I think sometimes that the power of that relationship that between social worker and person, I think can offer lots, can't it? Can offer, and if you build that relationship over a period of time, I think, and people that I've worked with in the past and felt that I was able to manage crisis in a different way because I'd built relationship up with that person and been able to support them through that time without chucking lots of services in. You know what I mean? And I think that approach, the input that a social worker can offer, I think can offer real power and value to that person.
I've just recruited quite 3 or 4 new social workers who have been used to being working out in the community and now suddenly are, and they've been working at homes under teams. I mean, they've been, every day, they've been, 18 months they've been in offices and are now coming into a hospital. Obviously, as a hospital, we're open all the time and they are coming in, which they're really enjoying actually being part of a team again and coming into work. I mean, that's been, for them, one of the joys of working in a hospital is coming back to the real face-to-face work with people. Every day they're coming in and can build those relationships with those patients and service users. Every day it's about building some of those relationships. But at the same time, they're having some quite challenging conversations with patients about what that might be, about some of their insight into what's happened, what is available out there in the community, how we're going to balance, some of their meeting their needs, but with the balancing the risk with other people out there. Being on the ward every day, I was just interested in about the I think it was the point 12, isn't it, in the standard around about dangerous situations. And we talk about that quite a lot, about going on the ward and about how you have to not be complacent being on the ward, that you've built a relationship with a service user on the ward, but you're always still mindful of the risk that they may present. And you have to, you could, be quite easy to think, well, I built that relationship, I don't feel there's going to be any harm. But, people here are, unwell. Some of their behaviour is unpredictable. So they're constantly kind of juggle some of those risks actually on the wards on a day-to-day basis.
That's a seamless link, George, because that was my next point to bring up. Because we can't talk about safeguarding without talking about the crisis and the dangerous elements that comes with safeguarding referrals and safeguarding work and safeguarding investigations and all the things that comes around it. Sometimes the impact that can have on the social worker's own well-being, and I'm really keen to get people's thoughts on that around how you've managed it in the past, but I think how that might have changed over the last sort of 12, 15 months where maybe social workers haven't had that office space to come back to and reflect and debrief. Keen to get your thoughts on it.
We've slowly started to integrate back into some office-based work. We are moving toward a corporate stance in the near future, where we're going to have a split between office-based working again, but also continuing to work from home. And, in terms of the office-based working, practitioners are very keen to have that and have that coming together, because the importance of peer support and being able to offload on one another and get support around particularly a challenging circumstance. Whilst we've supported each other over the likes of Microsoft Teams, and we've been able to make use of virtual technology like we're using now, that does not replace the kind of social contact between peers and how important that is in terms of being able to manage the emotions that the job can kind of provide. You talked about earlier about the impact of COVID. Safeguarding hasn't stopped. We talk about responding to dangerous situations where there's risks, etc. There has been some partner agencies that we work in partnership with that scaled back, that didn't provide a service where they were going out to see people. My perspective, whilst we had to be very careful about our own safety, our own kind of health and well-being, we still needed to kind of respond to safeguarding concerns. How can you judge a situation over a phone call? You can't always. You don't know whether they could be presenting duress. You don't get that visual perception where you're able to pick up on potentially other forms of abuse or neglect, etc. So, we very much people often ask me, how's your practice changed during COVID? Well, in all honesty, it didn't.
Yeah, and I suspect you're the same, George. I suspect your practice didn't change?
When I came to the hospital, it was kind of mid-COVID, and so for us, the social workers are coming into the hospital. Most days they're coming in. If they're writing tribunal reports and things, and some of those things, obviously they would stay at home. But for the most part, the social workers are here are on the wards. I suppose the difference is for them is they're all in scrubs and goggles and masks, and that's quite different in itself coming down onto a ward. It does, even just in terms of, it does present a bit of a barrier, I think, when you're having conversations with people. But what I'd also say is, in terms of the stresses in the hospital, when we've had periods of lockdown where patients haven't been able to have as much contact with family and friends, haven't been able to have any leave, that can present quite a challenge, with behaviour on the wards, because people obviously are very stressed if they're having to isolate and stay in the hospital, and so that can bring some safeguarding issues into the hospital. I think, really, as is with staff, it's very, very difficult when you cannot go out, isn't it?
It's interesting you refer to that, George, as an impact that you faced within the hospital, because from a safeguarding perspective, when kind of lockdowns were implemented, we certainly saw spikes in kind of like physical incidents between residents in shared care settings. So obviously with things like LD, day provisions and stuff shutting down, it meant that routines, etc., had all changed. And we did see spikes in terms of incidents being reported as a safeguarding concern.
Yeah, it's a significant challenge, isn't it? When people can't go out, their routines have changed significantly, aren't they? And they are in a hospital where they can't leave, isn't it? And although we've done lots of stuff about, the Teams calls with family and friends, using the internet to kind of, to ensure that there is contact, it's clearly not the same, isn't it? If you are used to your family coming in to visit, but we weren't able to allow families and friends to come in. And that's the thing, isn't it? We know those support networks are what keeps people's mental health generally, helps your well-being, doesn't it? When you are seeing family and friends and getting out and doing things, isn't it? That's what really helps your mental well-being. Not to mention the impact on the staff, who are struggling. Well, staff have worked really hard to keep everybody safe. We need to keep our patients safe. And the biggest risk for the patients is actually us as staff bringing COVID in. It's a significant challenge still.
And you've touched it a few times, George, around just the importance of good supervision throughout this and beyond. The importance of good supervision in social work is never going to change. But I think particularly through COVID, and I know it's changed, it's been online, it's been through Teams and Zoom, but I think in that good quality support for social workers to help navigate everything. Do you know what I mean?
Calum was talking about the peer support, and I would say here definitely as well, because for me, I've got each social worker is on a ward. And I think my normal experience of working in a social work team is you're all in a room together, aren't you? And you're sharing the work, you're sharing the knowledge, policies, procedure, some of the difficult things and complexities, and you've got that peer support to manage it. Here, it's one social worker per ward. So you have a responsibility to have that social work voice on a ward. So that peer support outside of that is really, really important. We have some social work forums that really help us with some of that.
Yeah, we've introduced a number of forums in terms of being able to support our staff, ranging from reflective supervision sessions where kind of groups of people can come together to kind of reflect on different areas of practice. But I'm a firm believer that supervision is an ever occurring thing. It isn't just something that's a protected 2 hours every fortnight or every 4 weeks. It's an ever occurring thing, and I definitely try and deliver that message to the staff I support. And it's not just the supervision that I'm able to provide. It's the supervision for me also includes that support from others, the peers. There has been an impact on some of that in terms of, yes, we can communicate via Teams, but it just doesn't replace that face-to-face contact. Just, coming to and from an office where you were able to kind of reflect and unwind before you enter back into your kind of home life. That for me, that's a big impact. And I firmly believe that is something that is impacted almost everyone that I certainly manage at some point, is that work and home life separation.
And I think it's such an interesting point to make. And I think that I was just thinking there, reflecting on my own practice, because I only ever worked in Cumbria, which is a really rural county. And I spent a lot of my time travelling. So I would go and see one person, then I'd have to travel 45 minutes to go and see another person. That 45 minutes was incredibly valuable to sort of think about what had happened, think about the things that I needed to do, think about the decision making, thinking about the people I needed to talk to. And without that, and I'm the same. I've worked at home now since March, and I finish work, I open that door, and I'm back to being a dad.
Yeah.
So if you were to talk to social work students about safeguarding, what would be the one piece of advice you would give?
Don't be scared to make a decision. Keep the person at the centre of your practice at all times. Focus on their strengths. Whilst you might be dealing with a concern where risk has presented itself, don't see that as a problem. I think, like I said, it's around promoting well-being and keeping that person at the centre and ensuring that your decision making is defensible. Work to them kind of core principles. You won't go far wrong. Yes, you'll be stressed. Be prepared to be stressed. But that's the nature of the beast in this field of work. And I think it's really important that we're able to build some emotional resilience to the stuff that we're faced with at times.
Well, I suppose that the one overarching thing is about keeping that being, which is what Callum's already said, really about being person-centred, isn't it? But I suppose it's a bit of a reminder of some of that stuff around about recording, I would say. Make sure that you have what you're doing is evidence-based, that you've got a good rationale for what you're doing and you're recording what you can do. Because what we all know in anything, when things go wrong and people look at the paperwork, even if you've done it, if it's not recorded, it hasn't happened, has it? So there's something about being recording it. And I would say also really think about using some of those resources, keeping your CPD up to date. And we are an evidence-based, critical thinking profession, aren't we? And so you have to constantly be holding that in mind. I think. So I use Twitter all the time. That's a really key thing. I would say go on Twitter would be my key thing, because actually you can really keep up to date with all the latest research and stuff that's going on, because thinking does change. You love this, Matthew. I'm constantly saying to my team, don't wait till November to update your CPD. And we introduce it in our team meeting to keep your people's learning up to date, for people to bring something that's current in research. Constantly keeping your thinking up to date, I think, really would be a key message for me.
And the one that I'm going to add in is around decision doesn't have to just be made in isolation by yourself as an individual social worker. And I think that's really important to always remember, whatever stage of career you're at, however experienced you are, link into other colleagues, link into your manager, link into other professionals. All those types of conversations will really help you to inform that decision. It's not about passing blame, and it's not about not wanting to make the decision yourself. So to end, a really big thank you to both of you.
No, it's been a pleasure. I've really enjoyed it, and I think I'll be probably logging on to record this as an example of CPD as well.
We'll end on a plug to upload some CPD. I'm more than happy with that.
Thanks again to George and Calum for joining us today and sharing their personal experiences of social work so openly. If you enjoyed the discussion and would like to continue the conversation with us, you can follow us on Twitter and LinkedIn using the hashtag #ThisIsSocialWorkPod to share your thoughts. You can also find out more about the professional standards on our website. Join us for our next episode, where we'll be talking about Standard 4, maintaining my continuing professional development. Thanks again, and see you soon.